we are here with the Professor Zobair Younossi, and we are at the ALEH meeting in Peru. So I'd like to ask you two questions. One, why do you think that MASLD is more prevalent in Latin America? And two, can you give us a little glance of the association between alcohol, MASLD, metal-D, and NLD? And this is a problem worldwide, and what we can move forward to get better.
Absolutely. Well, thanks for having me. I think the exact reasons for why the prevalence of steatotic liver disease, or maybe specifically MASLD, is very high in Latin America. Remember that there are multiple components of what contributes to development of MASLD. There is those that are environmental, and this would be things that we do in terms of activity, diet, the ultra-processed food, high sugary sort of beverages, and then some are fixed, specifically genetics. So the combination of both can actually drive this disease. I would suspect that it has that in Latin America, it's probably a combination of both. Some SNPs or genotypes that are more associated with not only MASLD, but also progressive form of MASLD may be more common, at least in some countries in Latin America. Second, there is also probably consumption of processed food in other things that are in the environment that we haven't actually really estimated very well. What's the impact of pollution? What's the impact of using different kind of chemicals for agriculture? All of those things we need to understand, but it's the combination of both that leads to prevalence in South America. And finally, we now know that there is an interaction, and this also leads to your second question, between the MASLD risk factors and alcohol. So for example, if you have MASLD, you have fatty liver, and even if you drink a small amount of alcohol, it can actually cause more progressive liver disease. So I showed some data today showing that for men with very high waist to hip ratio or central obesity, even one drink a day can actually increase the risk compared to those that are not. Now, moving to the future, I think the new nomenclature has MASLD, met-ALD, which is basically drinking a moderate amount of alcohol, but having a cardiometabolic risk, and then alcohol-associated liver disease, which is basically drinking excessively. Remember that patients who have ALD, 90 to 95% of them will have at least one cardiometabolic risk. Well, that's because alcohol can cause obesity, can cause dyslipidemia, can induce actually insulin resistance and diabetes. So, in what I'm actually sort of getting to the point to appreciate this better is that these spectrums that we are talking about, MASLD, met-ALD, and ALD, they are not fixed diseases. Maybe in some patients it will be very, very pure ALD, and some would be very, very pure MASLD, but they all move over time because people, drink and stop, or they can lose weight, or their diabetes is controlled. So this is a dynamic sort of process that goes on. How do I have actually evidence for this? If you look at clinical trials of drugs, when you look at the placebo, quote unquote, rate, there is a high placebo rate. Well, how do you explain this? It's not just by the fact that you have liver biopsy. If you look at the outcome of NITs, you see the same placebo rate. So I think that during the clinical trial, people improve sort of their metabolic sort of diet and metabolic milieu, but also change their alcohol habit, alcohol consumption, and that actually could at least be partially responsible for the placebo effect. So when we move to the future, I think we have to have better assessment of alcohol consumption with either a questionnaire like AUDIT-C, followed by a blood test like PET test for some. And then the other thing, of course, would be to make sure that we get good dietary intake, not just by history, but something with food frequency questionnaire that's validated, so that you understand exactly how these things work together. And also understand that this is a dynamic process, and when we design clinical trials or clinical studies, we have to have a better understanding of the mechanism changing and really address that at the patient level or at the cohort of the clinical trial level.
Perfect. Thank you very much.
Thank you. My pleasure.